P.A.D, poor circulation in the legs, is somewhat easy to understand, but the widespread impact on people of color and the disparities in care is not. We have a renowned P.A.D researcher, Mary Yost, who's devoted her life to researching disparities and raise awareness about them. Her work has a profound impact on improving care for people of color with P.A.D, and this is why she earned the Lifetime Achievement Award from the Global P.A.D Association, and why we are so honored to have her here today to take a deeper dive into her passion and knowledge. Let's welcome Mary Yost. Good morning, Mary.
Sorry, I was busy listening and I had to unmute. Can you hear me?
Yes, ma'am, we can hear you.
Thank you so much, Charles, for such a very nice introduction. And also, I want to thank Charles and Kim for asking me to speak today. This lecture is based on a detailed report I published in early 2022 on P.A.D. and African Americans. And so I'm going to talk about the Black amputation epidemic. I have about a 20-minute lecture. First of all, we have the amputation lottery. The probability of a major amputation depends on who you are and where you live. An amputation varies by age, race, sex, socioeconomic status, hospital volume, and geographic location. And Medicare and Medicaid patients are the most likely to undergo amputation, more likely than private insurance patients, and Medicaid are the most likely. So if we look at the amputation lottery in African Americans, we know that Black race independently predicts amputation, and Blacks have a higher risk for major amputation, 1 to 4 times more likely than Caucasians. And African American females are the most likely to undergo major amputation, with a risk that's 7.6 times higher than other females and a higher risk than Black males. If we look at major amputation by race, what we see is for all CLI patients, 24% undergo amputation, but 41% of Black CLI patients undergo major amputation. We look at Medicare amputees. What you see is there's a higher percentage of amputees that are Black that undergo above knee amputations, and a higher percentage of Black females undergo amputations versus white females, 58 versus 46. Let's talk about P.A.D. in Black Americans. If you look at the population, ages 45 and older, 12% is Black. But if you look at the P.A.D. population in that same age group, 24% is Black. These are my numbers. And I want to talk about asymptomatic atypical disease, which I shorten as ASAT disease. I'll explain what that is in a minute. This is very important and it's not talked about very often. If you look at a disease by severity in Blacks versus P.A.D. in all races, what you see is that Blacks have a higher percentage of this ASAT disease, 70% versus 63%. Now, what is ASAT disease? Okay, asymptomatic disease and atypical disease are both characterized by abnormally low ABIs. The difference is asymptomatic disease does not have leg symptoms, but atypical disease has leg symptoms. They're just not intermittent claudication. And some of the most common symptoms are leg pain on exertion and rest, and leg pain with the ability to carry on walking. If we look at Blacks, let me just talk about ASAT. First of all, it's not benign. This is not a benign condition. All patients, even those who are asymptomatic, have functional impairment and decline, mobility loss, reduced leg strength, and adverse changes to nerves and muscles. So something negative is going on even in the legs of those asymptomatic patients. And ASAT patients experience a faster decline in mobility and greater mobility loss than those with intermittent claudication. Specifically, Blacks with ASAT disease have more severe disease and have a lower much poorer lower extremity function. They're more likely to lose mobility and less able to walk for 6 minutes without stopping. Now, critical limb ischemia, again, 12% of the population 45 and older is Black, but 30% of the CLI population is Black. And in African Americans, more likely to present with critical limb ischemia. And African Americans present with more severe ischemia, more likely to present with gangrene rather than ulcers or less rest pain. And gender plays a big role here. African American females have a higher percent prevalence of CLI than white females. And Blacks, both male and female, have a higher risk of being hospitalized for critical limb ischemia. Let's dig into some of the causes of the P.A.D. disparities. Now, in my opinion, you can't just say there's one cause. There's multiple causes, and they're all interrelated. There's low knowledge and awareness of this disease and its consequences. There's discrimination. There's a higher prevalence of certain key risk factors, such as diabetes, chronic kidney disease, hypertension, etc. Multiple risk factors play a role, and they have a bigger impact on Blacks than whites. Lower socioeconomic status, geographic location, and residence in distressed communities, female gender, and there are also genetic variants, although the study of genetics in P.A.D. is still in very early days. So I don't have time to go into all of them, but I'm going to hit on certain key variables. So if we start with risk factors, diabetes. The prevalence of diabetes in the entire population is much higher in Blacks, 20% plus, versus the entire population, 12%. Prevalence of diabetes in those aged 65 and older, for over 47% versus 32%, and age is a key risk factor for P.A.D. We also have a higher prevalence of diabetes in Black P.A.D. patients. 43% of Blacks with P.A.D. have diabetes versus 27% of whites. And why is that important? Well, diabetes has a very significant impact on P.A.D. severity and outcomes. Diabetics have more severe disease. They're more likely to present with ulcers and gangrene. Critical limb ischemia develops suddenly in diabetics. There are more amputations and a much higher risk, and the risk of amputation increases with the severity of diabetes measured by HbA1c, in other words, adverse blood glucose. Chronic kidney disease, another disease that's higher prevalence in Black P.A.D. patients. 39% prevalence in Blacks versus 26% in whites. And these are P.A.D. patients. And again, chronic kidney disease has a huge impact on P.A.D. It's an independent risk factor for P.A.D., increasing the risk up to 4 times. And Blacks with CKD have a higher risk of developing P.A.D. than whites. Risk of P.A.D. increases with the severity of chronic kidney disease. And in CLI patients, CKD increases the risk of heart attacks and strokes and other cardiovascular events, mortality, and amputation. Now, end-stage renal disease is also much higher in Black P.A.D. patients than white. 25% of Black P.A.D. patients have ESRD versus 15% of whites. And again, this has a really major impact on the disease and the disease process. ESRD increases the risk of amputation. A recent study found that it increased the risk of amputation by 7 times. And the risk of amputation increases with the severity of ischemia. So if the patient has gangrene rather than intermittent claudication, there's a much higher risk for amputation. And ESRD predicts primary amputation, that is, predicts having an amputation and nothing else being done to the patient, predicts lower survival, lower limb salvage rates. Dialysis significantly increases the risk of death and major amputation. And African Americans have 2 to 4 times greater risk of ESRD than whites. And finally, this is one of the places where we do have data on genetic factors. There's an APOL1 risk variant that has been shown in African Americans to contribute to higher risk and faster disease progression to a more severe P.A.D. Hypertension, also more prevalent in Blacks. In the general population 18 and over, 57% of Blacks have hypertension, and whites 44%. I wasn't aware that hypertension was actually this prevalent in everybody. The prevalence of hypertension in P.A.D. is off the charts, 94% in Black P.A.D. patients, 82% in white. And again, Same thing, hypertension increases the risk of PAD, increases the risk of PAD hospitalizations, amputations, revascularizations, and death, and also increases adverse cardiac events, heart attacks, strokes, and mortality. And I have concluded that, among other things, PAD disparities in African Americans are also gender disparities. And it turns out the female gender is strongly interrelated with the majority of PAD variables in African Americans. And Black females have a higher prevalence of PAD. They're more likely to have CLI. There's a higher prevalence of risk factors such as diabetes, chronic kidney disease, hypertension in Black women. There's also a greater impact of risk factors in females in general. For example, CKD increases the risk of PAD in females versus males. Multiple risk factors have a much greater impact in females versus males. And then finally, socioeconomic status is another factor. Black females, lower income, more Medicaid insurance, more poverty, greater likelihood of residence in distressed communities, and these distressed communities have a higher prevalence of cardiovascular risk factors. So another variable here, delayed diagnosis. Now, we've seen from the Euclid trial that if a patient has CLI versus a patient that does not have CLI, that increases the risk of both major and minor amputations. And even within critical limb ischemia, another study showed that 4-year amputation rates are much higher as critical limb ischemia gets more severe. So Rutherford 4 patient with rest pain has 4-year amputation rate of 6%, but the patient with gangrene, that's Rutherford 6, has a 30% amputation rate at 4 years. And PAD diagnosis is delayed in Blacks. Now, it reflects the higher prevalence of this asymptomatic disease, the atypical symptoms, misdiagnosis, and also, I think, the low awareness of PAD as a significant cause of morbidity and mortality in the non-specialist healthcare providers and also in the Black community itself. Diagnostic testing is underutilized. This is for everyone, not just by race. Between 45 and 82% of major amputations have no angiogram performed before that amputation. And unfortunately, it's been shown that an angiogram reduces the odds of a major amputation by 90%. So you're much less likely to have an amputation. It's also, diagnostic testing is also underutilized prior to minor amputation. Now the question is, are Blacks less likely to receive diagnostic testing? The data there is mixed. Some studies say yes, some studies say no. Revascularization is underutilized. Again, this is for everyone. Major amputation is frequently the first and the only therapy for critical limb ischemia. Between half and over 70% do not have a revascularization. And what we see here is, if you look at amputees, the number of revascularizations prior to the amputation by race, what you see is that one revascularization, only 24% of Blacks had one, but 32% of whites. By the time you get to 3 revascularizations, nobody had them, just about, but 2% of Blacks versus 4% of whites. Medical management is inadequate. Again, this applies to everyone. However, we know that PAD is considered a risk factor equivalent to coronary disease. And it has also been shown that, by several recent studies, have shown that less than 1/3 of the patients with PAD are treated with all 4 guideline recommended therapies. We also know that cardiovascular risk factors are undertreated in Blacks with PAD versus whites. And antilipids, antiplatelet statins, high-intensity statins are underutilized in Blacks versus white patients. And in particular, this is important for statins because statins have been shown to reduce the risk of major amputation. And cardiovascular risk factors are even more undertreated in women, in Black women versus white women. And again, statins underprescribed. The impact of this suboptimal medical management, one study showed that it increased the risk of amputation and or death by 8.5 times. Glucose, abnormal glucose, increases the risk of amputation, reamputation, and revascularization. And the risk of amputation and reamputation increases in a dose-response manner as glucose levels rise above normal HbA, that is HbA1c, the blood sugar levels greater than 6%. And glucose is woefully controlled in diabetic CLI, PAD CLI patients. It's inadequately controlled in 63 to 92% of these patients, and Black patients are less likely to achieve adequate glycemic control. And if you just look at an example of the poor control in Black diabetics, this is the percentage of Black diabetics with HbA1c greater than 7%. What you see is 52% of Black diabetics have abnormally high glucose versus 46% for whites. Knowledge and awareness, it's not just low, it's abysmal, and it's particularly poor in African Americans and Hispanics. The most recent 2018 AHA survey found that less than 50% of people were familiar with PAD, the leg symptoms, and the risk of amputation. And they found that Blacks and Hispanics had the lowest awareness and the greatest knowledge gaps. And in particular, only 6% were aware of the symptoms and the risk of amputation. Now, Dr. Nanu showed this version of this slide. I just want to emphasize again, this is 5-year mortality. Breast cancer, 9%. In October, you can't get away from the pink ribbons. Everybody's heard of breast cancer. 27% 5-year mortality for PAD, 60% for CLI, 77 to 85% for major amputation, but no one has heard of PAD, let alone critical limb ischemia. We also have lack of referrals and delayed referrals to specialists. One study, shockingly, of internists, nephrologists, and endocrinologists found that almost 3/4 used watchful waiting as a quote treatment for PAD, and close to 2/3 did not consider non-healing wounds a reason for specialist referral. So this was also touched on by the prior speaker. PAD is considered a disease of low socioeconomic status and high deprivation. Worldwide data has shown that socioeconomic status and high deprivation predicts hospitalizations, adverse outcomes after surgery, and major amputations. And I'll just go through some of the data on Black Americans, lower income and more poverty. Household income for Blacks, $46,000 plus versus $76,000 plus for whites. Poverty percentage by race, close to 19% for Blacks versus around 7% for whites and Asians. We also know that patients with low socioeconomic status receive less vascular care. And what's really depressing about this data is that it was just published and this stuff has not changed in 20 years or more. These were Medicare patients, furthermore, and almost 2/3 of Medicare patients who underwent an amputation did not have an angiogram or a revascularization. And low socioeconomic status patients were less likely to receive vascular care, that is either an angiogram or revascularization. And furthermore, this lack of care, low intensity care, increased the risk of mortality. So we know that health disparities vary by state, county, zip code, urban versus rural location. 80% of all disparities occur in 60% of zip codes. We also know that cardiovascular risk factors are more common in disadvantaged neighborhoods, and Blacks living in disadvantaged neighborhoods have more cardiovascular risk factors and less access to care. And in one study that looked at all the disadvantaged zip codes, what they found is that of the disadvantaged zip codes, 70% of them were Black majority versus 20% of all the zip codes in the US. And again, you've seen this slide or a version of this slide before. Basically, the highest amputation rates in different cities and around the country occur in zip codes that are majority Black. And when they looked at all the zip codes, the highest amputation rates occurred in, were over 75%, where the majority were Black zip codes. So I'll just say thank you. These are the hardworking assistants. And I do want to add one thing that's, I think, very important for patients. I show this slide because my lectures are pretty depressing about amputation and all this stuff. One thing to keep in mind, family history. Nobody talks about this much, but family history increases the risk of P.A.D. by 2 times. And the risk increases with the number of family members who have P.A.D. That's something to be very aware of. I don't know if we have data by racial data. There may be some more recent data on that. So
we're going to jump over to Charles. Charles, you have the first question for Mary. Go ahead and ask the question.
Thank you, Mary. Those statistics are real sobering. You gave us a lot to chew on. You seem incredibly passionate about P.A.D. and especially the shocking statistics for people of color. What's the catalyst or the connection that you have with P.A.D. that started your journey and the driving force for you?
Well, there's actually no simple answer, but I boiled it down. There's a number of reasons. There's a long, we could be here a half hour of me trying to explain this, but I boiled it down to one key factor, and that is it's personal. Now, I don't have P.A.D. I don't have P.A.D. in the family. I don't have diabetes. We don't have diabetes in the family. So why is it personal? It's personal because I identify with the mistreatment of P.A.D. patients. And here I have to go into a little bit of my healthcare situation. My entire adult life was characterized by very negative encounters with healthcare providers. I call these providers Attila the Hun. Some were female doctors. There were nurse practitioners. There was a whole gamut of providers. And the problem was I had a painful disease starting as fairly young adult. And then even after I had surgery for this disease, there were problems with the surgery. Of course, surgery creates problems. And when I went to the doctors, my symptoms were dismissed. They were ridiculed. I was misdiagnosed, and I was told frequently that I had emotional or mental issues because I had this pain. Now, I'll inject a little humor in this. It wasn't humorous when it happened in the 70s. I saw a doctor for pain, and her prescription was that I should go home and cook my husband hot meals. So you can see why I'm a little aggressive and angry. And I can tell you this kind of thing, this kind of experience has continued. I had an experience here locally with a respiratory issue. The nurse practitioner was completely unprofessional. And again, because of that, it took me a long time to figure this out because, as a patient, you sort of bury this stuff. It's very difficult to be a patient, and particularly, to advocate for yourself. And if you get, if you keep being told that you have mental or emotional issues, when you know that you really have pain and there's something wrong with your body, then, there's a real problem. Now, on the positive side, I will tell you, one of my positive experiences, this is a little bizarre, was when I had cancer. Now, the local folks were mixed. There were a couple of Attila the Huns here locally. But when I went to MD Anderson, which is a specialized cancer center, I had a wonderful experience. I mean, it was night and day compared to my previous experiences throughout my adult life. And I can tell you that cancer patients are almost coddled compared to other conditions. And that's good. It's as it should be. You should be treated as a serious individual who has real problems, etc. But anyway, I'm babbling on. You can tell it's personal.
Well, thank you. We have one of our other warriors that would like to ask you a question. Juanita?
I can't
Is
hear.
Juanita muted? Is Juanita muted?
We can actually go ahead and we can jump to Douglas. Douglas, you have a question for Mary. And Mary, I just have to thank you so much for your vulnerability. I mean, you almost brought me to tears there. I mean, so many of us can relate to just, you know, when you don't feel good and people aren't listening and there's no solution, it just is even more distressing. It exacerbates even what you're feeling in that moment. So thank you so much for sharing.
Can you hear me?
Well, we can hear you, Juanita.
Okay. Again, I'm sorry.
Go ahead.
Again, Miss Mary, like I said, I want to thank you so much for sharing your personal story with us, because we have so much in common when it comes to this. I want to personally thank you because you didn't have to share that with us. But my question to you is, what is the most frustrating factor when it comes to the research that you've already done, the things that you know about this disease? What is the most frustrating for you that you've gone through?
Of course, it's hard for me to ever give a simple, answer. Two things. One is that, excuse me. One is that when I published the report on African Americans,
you fit that in.
it was, I knew it wasn't going to be a bestseller, but a lot of my clients are primarily industry, okay, and I sold a few reports, but there was a lot of indifference, and one client actually said, "Well, there's no clinical relevance," and I'm going, "What?" Because I didn't get into it in the lecture, but Black patients tend to have more below the knee disease, which is important. And that tends to be calcified, et cetera, which is more difficult to treat, and on and on and on. Mm-hmm. The other frustrating thing is that the numbers on P.A.D. that are routinely, the prevalence of P.A.D. that's routinely published were really good numbers for 1995. They're totally outdated for 2020, or we're now going to 2025, because the prevalence of diabetes has increased dramatically in the two key age groups, and the population has aged. And I finally got irritated with seeing 8 to 12 million. And I had some time earlier this year. And so I published an article in Vascular Disease Management pointing out that, if you just did the math on the original numbers, the 8 to 12 million was actually never, it was just like a back of the envelope calculation. It wasn't, based on a study. It was based on a study, the San Diego study, that was 800 some white upper middle class individuals, and they had some restrictive definitions of P.A.D. Mm-hmm. If you just took that data and applied it to today's population, it's math, it's simple. I mean, this is not calculus or anything. It would be something like, I can't remember, 18 or 19 million. And the problem is, it's not that you have to use, that one has to use my numbers, but if you're going to address a problem and fix the problem, the first thing you need to do is figure out how big is the problem. And then you need to figure out what are the causes of the problem. And if you look at more, contemporary numbers, the problem of P.A.D. is bigger than the problem of coronary disease. It's about 3 times bigger. Don't quote me on this. Several times bigger than cancer, all cancers, not just breast cancer. And it's bigger than stroke. And so, not downgrading the numbers, having the wrong numbers is actually doing a disservice to, helping get the word out and helping patients and creating awareness, et cetera, et cetera. So, sorry to rant on, but
Okay. So Mary, you have all the numbers on paper. Right now you have a virtual room filled with the faces of P.A.D. Do you have any questions that you haven't been able to ask an actual patient that you would like to ask?
yeah, because I don't get involved with patients. I have two questions. One in particular is about leg symptoms. I have a theory. My theory is that Black patients come in and they don't describe intermittent claudication from the textbooks. They describe something else. So I'd really like to know, what are the symptoms that patients have had when they've gone to the doctor? And my other question is, because I've been doing this for over 20 years and nothing much has changed. How do we educate patients about this disease? I've always said when I'm asked that question, I say Oprah. So how do we change it? How do we educate patients? So either of those questions, I think I'd be happy to know what the answer is.
I will say for me, I knew nothing about peripheral artery disease, and I was a dialysis patient for 9 years, and until I got my kidney transplant. Um, I learned nothing about that. I didn't even know it was a thing. Um, so education would be huge, and if with today's social media and celebrities and influencers, I think that would be a great way to get the word out about P.A.D, because it's just not widely talked about.
But did you have any leg symptoms?
I did for years. I would walk and have pain in my legs, and we just kind of brushed it off as a long day at work or just standing too long.
Right. Um, because one of my doctor friends has told me that his patients, and they're primarily Black patients, describe all kinds of symptoms that aren't written up in the textbooks, and they have P.A.D. And I
Yeah.
think I think that it's probably this atypical disease, whatever, that I think the healthcare establishment needs to get into that area a lot more. There's only one doctor that's actually done a lot of work on that. That's McDermott. But I'm also assume that people will go with ulcers and gangrene to the doctor, and again from the data, that gets ignored, or like the survey I said, 2/3 of the doctors that you go to will say, oh, well, it's not, we don't need to refer you to a specialist. No?
So when I went to the doctor, I complained about my pain in my legs. And the only thing that was done, there was no checks done, nothing at all. Just painkillers was given and a bottle of calcium tablets. And it was told to me, take the painkillers and take the calcium tablets every evening.
When you show up and you are having complaints, now your complaints regarding leg pain might not be related to P.A.D. at all, which is fine. But the most important thing is we need to get to the bottom of it. If it's arthritis, we need to find out whether it's arthritis. If it's related to P.A.D. So it starts by just taking off your shoes. I, as a medical provider, I need to take your shoes off. I need to look at your feet. I need to check your pulses to see whether do you not have good pulses? And if you have good pulses, I need to move your ankle to see, do I feel any joint issues that aren't happening here? It's the equivalent of walking to somebody's house and they say, every time it rains, my house leaks. Well, you need to find out what the problem is. You just don't walk in and fix the door, meanwhile it's the roof. So we have to spend that time, as much as I had to use this analogy, when we treat people. And sometimes we just don't do that. And I think that's an issue. You brought up regarding education. We need to do a better job of educating the public at large, so the community, but also healthcare providers. Mary mentioned something very interesting, which is also heartbreaking for me. She went to doctors and said, I have a problem. And her issues were overlooked. She was even insulted by being attached to illnesses she didn't have. That's not what she went there for. Now, can you imagine if you don't have access to care? She had access to care. And those things didn't happen. So we can definitely do a better job of doing that. And another thing I like to do, what I learned from one of my professors doing my training, is I like to take things and really, really just simplify them. It helps me understand them, but it also helps my patients. Meaning, when I meet a patient that shows up in my office, I'm talking about P.A.D., I use analogy of plumbing, of highways. I tell them, if you walk into your house, you go to your kitchen, you turn the sink, and water's dripping. Well, we know there's either a problem with the city water coming in, the pipes aren't good, or your pipes in your house. I like to use the simplest analogy because it helps me understand what I'm talking about, but also to explain to them. Because when I go to my accountant, that's what I expect from him or her. Because I don't know anything about accounting, but I want somebody to break it down to me. When I have to get my house fixed, when a carpenter comes in, I don't know anything about nails, but I want he or her to explain to me so I can get it. So it is our duty to do the same thing. So if I can break it down that way.
Thank you for that. I mean, I really appreciate it because it is something that even with my son, that was just diagnosed as a diabetic a week ago. They diagnosed him with diabetes. The doctor gave him his tablets and was said, take it at night. And that was all. No education, nothing, no referrals to a dietitian or a eating plan. And it goes to say I'm suffering with peripheral arterial disease, kidney disease, hypertension, and amputation with pain all the time. And getting education or the awareness of the NCD side of everything is actually limited. So
Yes.
I really appreciate what you, Dr. and Mary said. What is the other question is, what is the way forward from here?
Yes.
To actually get that education out there in the layman's terms, like you were explaining now, for the plumber, the carpenter. It is beautiful. So I, as a layman, can actually understand my condition to the fullest.
Yes. No, that's a great follow-up on that question. So two things. Unfortunately, we live in a world where really the things that get attention necessarily don't deserve the attention, but they do get them. Both Mary and I emphasize on breast cancer. I have a slide that I didn't share today, and I'm glad you are from South Africa. I have a slide of the South African national cricket team, and they're wearing all pink at a game. But all of us know that the breast cancer is probably not even in a top 20 cause of death in South Africa. But they get that attention. So what we also need an advocate, whether it's a sport figure or, like Mary say, Oprah, somebody that has a platform to talk about this illness. That's one thing I think we all need. And then we also need to be unified. Unfortunately, there's a lot of fragmentation in the kind of care that we provide. Multiple societies have different ways of doing things. The care is not uniform. And so all of us coming together really makes a big deal. And it has to be a front that's all the specialists providing care. People like Mary who have the data, who understand the demographics and the impact and the magnitude of the illness, and patients. Because this is what happened in the breast cancer community. You have patients, you have the families, you have healthcare providers, you have industry, you have the sporting world, all combined, and that's why they get the attention that they get. And one more thing I want to emphasize, I have three men in my life who are really important to me. One of them is my father, who lives in Canada. The other is my father-in-law, who lives near me in Florida. And the third is my uncle in northern France. Interestingly, all three men were diagnosed with prostate cancer. And interestingly, their prostate cancer were all at the exact same stage. And what's even more interesting, they were all treated the exact same way, even though they were in three different countries. You think they were treated by the same doctor. They got the same dose of radiation. They got the same medications, the same doses, all the same. What it means is that community has done a good job of coming up with a unified way of treating patients. And it didn't matter whether it was France, Canada, or United States, they got the same care. And here, Mary just presented, you go from one zip code to the other, your care changes. You are African American, your care changes. You are Hispanic, it changes. You happen to be a woman compared to a man, it changes. You show up in the emergency room of a tertiary care center,
Right.
but the doctor who happens to be on call is Dr. A. Your care is different than when you see Dr. B. It shouldn't be this. It should be the same. So we have a lot of work to do. And so maybe hopefully that answers your questions as well.
No, thanks.
Thank you
Back to
for
you.
that. Thank you for that. Mary, of course, I want to thank you for your time today and giving us those statistics. If anyone wants to see more of her research, please go to www.thesagegroup.com.